Thank you. Thank you for the invitation, Laura. And since we don't have cases, feel free to interrupt or ask questions or save them for the end or whatever, so that there should be plenty of time. These are my disclosures that my employer, the NIDCR, receives support for these conditions. Okay, so, and I did also want to thank my colleague, Rachel Gaffney, who helped with many of these slides. Anyway, so this really has been, in the last decade or so, a real boon for rare bone diseases. This was what things looked like in 1996, and in 2023, this represents really only a partial list of many of the new therapies that are either approved for or in development for rare bone diseases. I won't be able, because of time, to go into all of these, and those that I do go into will be somewhat superficial because there just won't be enough time, but I did want to give an array of the new therapies that are available and those interesting ones that are coming as well. So I'm going to break this down broadly into calcium disorders, phosphate disorders, and skeletal dysplasias, and I'll be covering most of those shown here highlighted in green. But first, a little bit of background to focus us, center us, and give some of the physiology, biology that'll be necessary to understand some of the disorders and drugs that we're going to be talking about. And so that's shown here. So bone really is, in many ways, a biological crystal. The most of bone is the hard stuff, and most of the hard stuff is hydroxyapatite, and most of the hydroxyapatite is shown in this crystal here. There are substitutions. Some of them are shown here: strontium, fluoride, and carbonate, and others can be, but primarily it's a biological crystal, hydroxyapatite, that's made up mostly of calcium and phosphate, and that's why these calcium and phosphate disorders are so important. So another really important molecule involved in bone biology and mineral homeostasis and calcification in general is this molecule called pyrophosphate. So pyrophosphate is the major biological inhibitor of calcification. And it's really important to have inhibitors of calcification because calcium and phosphate circulate in the blood and in the tissue are at concentrations very close to that of precipitation. And so without an inhibitor of hydroxyapatite formation, we would end up calcifying our vessels and our tissues after injury and that sort of thing. And that's what happens in some of the disorders that we'll talk about today. So pyrophosphate gets incorporated into this growing crystal of hydroxyapatite and poisons the crystal. And in so doing, prevents propagation of the crystal. And that's the way by which we prevent calcifying all over our body. Now, there are tissues that we want to calcify, of course, and that is our bones and teeth and some others as well. And the primary way that we do that is through this enzyme alkaline phosphatase, which is highly expressed in mineralizing tissues. And alkaline phosphatase is a pyrophosphatase that breaks down pyrophosphate and allows mineralization to proceed. And of course, as many of you know, bisphosphonates are a sort of analog of pyrophosphate. They, though, can get incorporated into the biological crystal of pyrophosphate, and they're therefore taken up and laid down in bone. And this is really how they work. Their mechanism of action is that osteoclasts sit down on bone and they begin to resorb, and some of these bisphosphonates are released and they poison the osteoclast. And that's how they work, and that's how this relates to all the mineral homeostasis that we're talking about. So with that then, as by way of background, I'll jump into one of the important and well-studied and now with new treatments, and that is hypophosphatasia. So hypophosphatasia is essentially alkaline phosphatase deficiency. With low alkaline phosphatase, and this is tissue nonspecific alkaline phosphatase, TNSALP, there's low levels of alkaline phosphatase, there's little pyrophosphate breakdown, there's little phosphate for mineralization, and this results in osteomalacia. I did just want to add this, that sometimes this clinically can be a little bit confusing, because when we see low alkaline phosphatase, we may think of hypophosphatasia, but previous treatment with antiresorptives can also lower alkaline phosphatase and sometimes can mislead us into thinking that this is hypophosphatasia. And part of the important thing here is that bisphosphonates, if they were inappropriately used to treat this, could make the osteomalacia worse. So hypophosphatasia is a disease of decreased mineralization with osteomalacia. Interestingly, and one of the important diagnostic approaches to diagnosing hypophosphatasia is that TNSALP is also needed for vitamin B6 metabolism. So one of the ways that you can support the diagnosis of hypophosphatasia is to check B6 levels, and they are elevated in hypophosphatasia. Also, patients will have a history of early tooth loss, and the tooth falls out as it looks like in this panel here, root and all. Adults with hypophosphatasia will often present with metatarsal fractures. This is one of the most common presenting features of hypophosphatasia. So it's an adult with a metatarsal fracture, comes in and has a low level of alkaline phosphatase. This is one of the radiographic signs of hypophosphatasia. These are two of the radiographic signs of hypophosphatasia, this hypolucent tongue and a so-called looser zone pseudofracture. So this has really been one of the major triumphs in the field of rare bone treatment, and this has occurred. This was the New England Journal article from 2012, and this was just, I've seen Michael White show the videos of these children going from, intubated in the intensive care unit to toddling down the hall. It really is a magnificent therapy. Very, very clever. There have been efforts for years to get alkaline phosphatase to the right tissue for this disease. And people tried implanting bone chunks. They tried infusing alkaline phosphatase. They tried infusing blood from patients with high levels of alkaline phosphatase, like Paget's disease, and none of it worked. But what did work is putting this decapeptide of aspartate onto alkaline phosphatase, which then binds this to hydroxyapatite, the forming bone, and it delivers alkaline phosphatase to the tissues that are needed. So this drug, alphatase alpha, Strinsic, was approved in 2015. It's very expensive. It's about $200,000 a month. And to treat an adult with metatarsal fractures for something like this, it can be well over $1 million a year. Good news is that there are new drugs coming. It's in development. Alexion makes this, and I don't know the status of this, but this is on the horizon. And I understand that this new drug may begin to address some of the cost issues that exist with Strinsic. Anyway, this is a real triumph in the treatment of hypophosphatasia, and even better news coming, I think, for this disease. Another interesting disease is what is called infantile hypercalcemia type 1. It is also presents in adults with idiopathic hypercalciuria, and this is due to CYP24A1 deficiency. So you can see what CYP24A1 does. It converts 25D to 2425D or 125D to 12425 vitamin D. And deficiency of this this enzyme can lead to increases in 125D. So this is why you have infantile hypercalcemia, and this high blood calcium with a lowish PTH is what leads to hypercalciuria in adults. So hypercalcemia, sometimes mild, a low or lowish PTH, a normal or slightly increased 125 vitamin D. Key features are hypercalciuria, nephrocalcinosis, and high 125D level leads to bone fragility and fractures. And it's due to biallelic inactivating variants in CYP24A1. So there's a new treatment being studied for this. It's actually an old drug that's available on the market. And so this is a very clever approach taken by Michael Levine at University of Pennsylvania, who has a study of this. And so it had been known for some time that rifampin can induce CYP3A4. And CYP3A4 promotes the inactivation of 25D and 125D to 123,25 dihydroxy-D. Rifampin does that, and it'll increase this, and it'll lower 125D. So taking advantage of this physiology, this was a study that Michael and his colleagues did and was published in 2017. And in patients with this disorder, rifampin normalized blood calcium, PTH, 125D, the urinary calcium creatinine ratio, and the drug was well tolerated. There's a study going on right now to look at this, and this is called the rifampin and CYP24A1 related hypercalcemia and hypercalciuria, the RICH study. And that's the study number for there. It's still ongoing at the University of Pennsylvania. And of course, rifampin is easily available off study to patients and could be tried by anyone, but would be best if this is done in the context of a clinical study. Okay, I'm going to turn to now hypoparathyroidism, for which there are a lot of therapies that are emerging. So treating hypoparathyroidism is really tricky. You're walking a tightrope. You're trying to keep blood calcium up and at the same time keep urine calcium down. The first one, keeping the blood calcium, is easy. Keeping urinary calcium down is hard. So, as I said, there's a lot of work going on in this area, and I'm just going to sort of summarize it in a slide or two. So the approved therapies, conventional therapy for hypoparathyroidism is typically calcium and calcitriol active vitamin D. Forteo could be used off-label. Natpara was recently withdrawn from the market. And these drugs really worked quite good at keeping blood calcium up. So keeping patients asymptomatic, keeping them from tingling and having seizures. But they really didn't work at keeping urinary calcium down. So that was a problem. They didn't really work that. So we have a number of therapies in development. Haloperidol, made by TransCon, is a pegylated form of parathyroid hormone. It would be a daily subcutaneous injection. It's under investigation. They completed the phase 3 trial. I think it was in May that the data were presented to the FDA. There were some issues related to, as I understand it, reliability or consistency of the concentration of the drug, especially at the highest concentrations. So that drug is poised, we think, to be approved once these issues are resolved, and should be coming available, we hope to us soon. There's also eniboparatide, long-acting PTH, which is a PTH-PTHRP chimeric. This is also a daily sub-Q injection. This is earlier along in studies, so we really don't know if it'll have this desired effect on urinary calcium, but it probably will. This is a drug that was developed by Tom Gardella at Mass General. And then the last one that's in development is encaleret, which is a calcilytic, an antagonist of the calcium sensing receptor. It's an oral medication, and it's been studied for autosomal dominant hypocalcemia type 1. So as I said, paloperidol is TransCon PTH is under review, re-review at the FDA. That should be available soon. Encaleret, which was a study that was done by us here at the NIH, Rachel Gaffney was the principal investigator. The results were beautiful. They were published in the New England Journal, just released last week. So this looks very promising too. My other colleague here at the NIH, Iris Hartley, is conducting a study with the same medication in post-surgical hypoparathyroidism. So if that works, that'll also be very, very exciting too. This is an oral medication, seems to have a really good safety profile, but all of these drugs are in development. Some will be available sooner rather than later. And it looks like the treatment for hypoparathyroidism is really going to get much better very soon. Okay, but the big problem in hypoparathyroidism, what I call sort of the final frontier, is bone turnover. And so this is what we really need to pay attention to. This is the head CT of a young woman that we saw here at the NIH who was treated with PTH replacement therapy with autosomal dominant hypocalcemia type 1, 14 years of continuous therapy, and it really had this almost brown tumor-like, fibrous dysplasia-like effect on the skull. So really, the trifecta of efficacy for the treatment of hypoparathyroidism that is not only normalizing blood calcium and urine calcium, but also normalizing bone turnover. So really, bone turnover is the final frontier in this. This is something that we really should pay close attention to in the results of the studies that are coming out, because this is a therapy that these patients will be on lifelong, and we have to know that it's safe for the bones after 10, 20, 30 years of treatment. Okay, so that was a whirlwind tour of hypoparathyroidism. And now I'll go into phosphate disorders. This is not really how clinical trials are designed, that when you run out of the mice, you move to the clinic. Believe me, it's really much more difficult than that. Anyway, so the phosphate disorders, as I see them, really are divided into the hypophosphatemia disorders, which are those with FGF23 excess, in which phosphate is low, tubular reabsorption of phosphate is low, FGF23 is high, 125D is frankly low or relatively low, the other effect of FGF23. PTH is typically on the low side, and calcium is typically normal or high normal, as opposed to hyperphosphatemia, FGF23 deficiency. And here, as you can see, intact FGF23 is very low, depending on the disorder. This was hyperphosphatemic familial tumoral calcinosis. The C-terminal FGF23 is quite high. The big deal in this order is you have a high phosphate, a highest calcium, and you have a high calcium phosphate product. And it's really believed that this high calcium phosphate product is required and permissive for the calcification that occurs in this condition, but not sufficient. These patients, because of the low intact FGF23, have frankly high or highish 125D and low or lowest PTH. Okay, how does FGF23 work? Well, FGF23 is made by bone cells, circulates in the blood, acts at the kidney to regulate blood phosphate and 125D. At the proximal renal tubule cells, it binds to an FGFR1 receptor, which is with its co-receptor Klotho, which gives FGF23 its tissue specificity, and inhibits 1-alpha hydroxylase and the NaPi2A sodium phosphate cotransporter. The net result is low blood phosphate and low 125D. The most prominent disorders of FGF23 are shown here. And as you can see, most of these are disorders of FGF23 excess, and some of them FGF23 deficiency. The condition name is shown here, the genes are shown here, and the results of the FGF23 are shown here as well. And so really the treatment of these in some ways is relatively straightforward. Conventional therapy for this consisted of phosphate and calcitriol replacement, and this was a very difficult therapy. It works a lot of times, especially with patients with milder disease, but it's a complicated therapy. You have to give phosphate 3-4 times a day, sometimes calcitriol. The combination of therapy can lead to hypercalciuria, nephrocalcinosis. Secondary tertiary hyperparathyroidism is really common with this condition. And then with the approval of this new drug, the FGF23 monoclonal antibody burosumab, this has really changed the treatment for disorders of FGF23 excess. It's approved for the treatment of XLH and tumor-induced osteomalacia, but it really theoretically and in practice by many of us is effective for any disorder of FGF23 excess. Short-term efficacy and safety are clear. It too is relatively expensive, about $200,000 a year, but it really was a true, like Strensiq for hypophosphatasia. This is a real breakthrough in the last 10 years for the treatment of disorders of FGF23 excess. I did briefly, for educational purposes, really want to go through the evaluation of patients with hypophosphatemia. So, patient shows up with low blood phosphate. You have to remember kids have higher phosphate levels than adults, so you make sure you're using the appropriate age-related normal ranges to look at this. Confirm that the cause of this is renal loss, and you do this by checking either TRP or TMPGFR. You just need to Google this. There are nomograms and calculators on the internet that can help you do this. And this really divides this into those causes of hypophosphatemia that are due to primary renal defects versus hormonal defects. I did want to make this one comment about FGF23 assays. So FGF23 assays can be tricky. The most commonly available FGF23 assay is what's called the C-terminal assay. And the way this works is that the capture antibody and the signal antibody just happen to recognize, both of them happen to be recognized epitopes on the C-terminal domain of FGF23. So in this assay, you can detect full-length intact FGF23, but you can also detect only the C-terminal biological clip of this as well. And this becomes important in certain conditions. Now, there is available what is generally believed to be a much better assay, and this is the intact FGF23 assay. The capture and signal antibodies are on the N-terminal and C-terminal domain of the protein. This is widely available, it's widely available, but it's not used widely. It's the only assay they're offering right now at the Mayo Clinic. Other places are offering as well. But the important thing to know is what is the nature of the assay that your lab is running for you. And as I said, C-terminal detects both C-terminal and the intact molecule. And I brought this up because this is important when diagnosing this disorder. So when you have your patient with low blood phosphate levels and you check the FGF23, if those patients have low FGF23, this points to the fact that the problem, and this is a whole other collection of rare disorders, is low. It is not because of too much FGF23, that the defect is primarily in the kidney. And these are so-called Fanconi type tubulopathies, where the patients have amino aciduria, proteinuria, bicarbonaturia, and calciuria. There's genetic forms, Fanconi syndrome, and acquired. Some of the acquired forms can be due to toxins such as lead and cadmium, and drugs as well. A collection of chemotherapy drugs, and tenofovir is one of the major culprits as well, given how widely prescribed tenofovir is now. About 15% of the patients on tenofovir will develop this sort of tubulopathy. There is a newer medication to replace tenofovir. I'm actually blanking on the name right now. I've not been completely convinced that it doesn't cause some of the problems, but tenofovir, but it's marketed as being less problematic in that regard. Of course, these are the FGF23 excess ones. Some of this we've already talked about, and most of these are genetic, and the acquired one is tumor-induced osteomalacia, which I'll talk about in a minute. And there's a number of metastatic cancers that have been associated with FGF23 excess. The one most commonly associated is prostate cancer. This is usually not a subtle diagnosis, though. These are patients who have fairly late stage metastatic cancers, and as sort of an oh, by the way, they also have hypophosphatemia due to FGF23 excess. And again, treating those patients, you could effectively treat them with burosumab, although that would be an off-label use of that medication. One tricky thing here is this: is what represents a low versus a high FGF23 when you're checking your plasma FGF23. In other words, what's the cutoff? So in the setting of hypophosphatemia, a C-terminal FGF23, which I talked about, of greater than 100, or an intact FGF23 greater than 30, and both of these are well within the normal range, these, in the setting of hypophosphatemia, equal an elevated FGF23. And this is by my colleague, Iris Hartley. So this is a very useful clinical pearl. Okay. One piece on tumor-induced osteomalacia. So tumor-induced osteomalacia is a rare syndrome of FGF23 excess caused by teeny little tumors called phosphaturic mesenchymal tumors. They're often difficult to find. The best imaging modality to find those is gallium-68 DOTA scans. You find the tumor, you cut it out, and they're cured. If you can't find the tumor, you can treat those patients as well with burosumab. It's approved for that indication. It works very well. But in the most difficult cases, and these are metastatic tumor-induced osteomalacia, and so 40% of these tumors are caused by FGFR1 translocations. This led to the idea that an FGF receptor inhibitor would be effective. The FGF receptor inhibitor blocks FGF23 signaling. It's tumoristatic. It really has significant, it's a tyrosine kinase inhibitor, really has significant TKA side effects, and it's reserved for metastatic tumor-induced osteomalacia. This was a study, again, by Iris Hartley in the New England Journal a few years ago. This was a patient who had widespread metastases. 1 year on the drug, his metastases melted away. Because of side effects, he had to go off. The tumor came back, 3 months on drug. And eventually, this guy who had widespread metastatic disease got 5 years of decent quality life through the use of infigratinib for TIO. The effect on the FGF23 levels were shown here. On drug, the levels dropped. They got high again. The drug worked again. Anyway, infigratinib for metastatic tumor-induced osteomalacia. Okay, what about ADHR? So this is autosomal dominant hypophosphatemic rickets type 1, excuse me. This was work done by Eric Immel and Mike Ekons at Indiana University, really beautiful clinical work. And they made the interesting observation that patients with ADHR really only developed FGF23 excess and hypophosphatemia really when they were iron deficient. So typical presentation is a young woman begins to menstruate, becomes anemic, and she develops ADHR1. And this phenomenon, that is a high FGF23 in the setting of low iron, is not seen in normal controls. So this really points to the locus of the defect in patients with ADHR. You and I have increased processing so that we can break down the excess FGF23 that's made when we're anemic. But patients with ADHR have mutations within the molecule that don't allow for this modification of FGF23. So when iron is low, they have high HIF, high EPO, high FGF23 transcription translation, and in control and a defect in post-translational modification in patients with ADHR1. So this, of course, then led to the idea that iron replacement might be a treatment for ADHR1. This was a study in the JBMR in 2019 by Eric Immel and colleagues, which showed very nicely that replacing iron in these patients with ADHR was an effective treatment for patients with ADHR1. Okay, ADHR2, which is due to variance mutations in ENPP1. sometimes called ENPP1 deficiency syndrome. And recall again, pyrophosphate critical for inhibiting mineralization. Pyrophosphate is broken down by alkaline phosphatase to generate hydroxyapatite to lead to mineralization. So in patients who have loss of function mutations, ENPP1, they don't make this mineralization inhibitor, and these patients can get widespread arterial calcification, sometimes called generalized arterial calcification of infancy. Horrible disease. 50% of these patients have die within the first 6 months of life. A really interesting feature, unexplained feature of this disease is shown here, and this may be related to those other 50% that survive for reasons that aren't entirely clear, and it usually isn't, quite possibly isn't related to the treatments that have been tried. And that is this, that virtually all of these patients with time will develop an increase in FGF23. So they have an age-related development of hypophosphatemia. The causes of this, as I said, are unknown. And this is an interesting area of investigation ongoing right now. Again, good news for this therapy is ENPP1 replacement therapy. This is a study by Inozyme Pharma. This was work, I wanted to say this. You'll be tempted to treat this FGF23 excess with burosumab, but don't do that because that worsens the disease and by mechanisms that aren't, again, completely understood. Anyway, this ENPP1 replacement, this is work by Dimitris Braddock at Yale University, where he developed an ENPP1 FC therapy. This is the results of the mouse study that are shown here. Wild type mouse, no calcification. ENPP1 mouse gets tremendous arterial calcification. And the treatment, with no treatment, these mice, virtually all of them die. And if you give this treatment, they do quite well. So yes, this is a phase 1/2 trial with the ENPP1 deficiency. I don't know of any early results from this study yet. Okay, turning our attention now to the other end of the spectrum, hyperphosphatemia. So again, this is FGF23 deficiency. The primary endocrine disorder of this disease is hyperphosphatemic familial tumoral calcinosis. And this drug is a real bear to treat. These patients can get massive ectopic calcification. They can get vascular calcification, wide spectrum of severity, but in the patients who have severe disease, it's really a difficult, horrible, largely untreatable disease. The existing drugs are usually ineffective, and these are to decrease phosphate absorption, so drugs like sevelamer, aluminum hydroxide, to promote renal phosphate excretion, drugs like acetazolamide, nicotinamide, probenecid, target inflammation, which is a common feature of this anakinumab, and to chelate phosphate topical thiosulfate. Again, we have a cohort of these patients at the NIH that are cared for by Kelly Roscoe. We've seen these patients for a cohort for about 15 years. We've tried all of these therapies, and in some patients, all of these therapies at once, and the effects are really not very good. Good news is there are emerging therapies. So there is this drug tenapanor, which can inhibit phosphate absorption. It's restricted to the gut. It's not absorbed. It inhibits the sodium hydroxy exchanger, isoform 3, and in so doing can prevent phosphate absorption, lower phosphate absorption from the gut. This drug is in the process of being approved for the hyperphosphatemia of renal insufficiency, I think. Other drugs in the pipeline, FGF23 replacement being developed by Ultragenyx. It's in the preclinical stages. And then there are also drugs that can promote renal phosphate absorption by inhibiting the sodium phosphate co-transporter. and these drugs are in preclinical stages as well. All right. Now I'm going to turn to the skeletal dysplasias, of which there are many. So I mean, Laura talked earlier about the new nosology paper that came out. And, you know, unless you're a geneticist, this area is very challenging for most of us. And I'm just going to talk about a handful of the more prominent skeletal dysplasias for which there are treatments that are either effective or coming. First, most prominent is, of course, osteogenesis imperfecta. And there are many causes of osteogenesis imperfecta, most of which are related to mutations in collagen itself. Then there is a whole collection of proteins that modify the collagen that also result in even rarer forms of osteogenesis imperfecta. Bisphosphonates really have become the standard of care. Bisphosphonates were started many years ago. Appropriately controlled trials were never done. They've come to be standard of care, and you know how to use them, when to use them, when to stop them, really is not clearly defined. And I think really part of that is that, again, I think that the trials that were done early on in this rare disease could have been better designed and conducted. And nowadays, I think we're doing those sorts of trials in these rare diseases, and we're getting much better information. Other treatments that are used for osteogenesis imperfecta, anti-rank ligand denosumab, I'll talk more about these, the anti-sclerostin antibody romosozumab, sirtuximab, and anti-TGF-1 beta. So I won't go into the bisphosphonate study. They really are the standard of care. And there are many papers that outline opinions of how you should do that. So more interesting of late was the use of denosumab in osteogenesis imperfecta. And the bottom line is there's probably not a future for denosumab in OI. This systematic review, which came out in 2018, said it was inconclusive. Some reports that it may be useful for type 6 OI, which has increased rank ligand. There were 2 open-label phase 3 trials that were being conducted in children and adults with an OI run by Amgen. And both of those were terminated due to calcium derangements, probably due to not enough forethought to the effects of denosumab discontinuation, or what can happen to mineral metabolism between doses. So there were severe derangements in calcium homeostasis, which can occur with either initiation or discontinuation of denosumab. And, you know, this was really something we knew about in the very beginning when this drug was first approved. And this was shown in this study in Bone from 2011. Actually, it wasn't in Bone, it was in JCM. The author was Henry Bone, was the first author. It was in JCM. Anyway, so what this study showed is that when you give denosumab, you have a really potent inhibition of bone turnover. This is the bone resorption marker CTX, and you can see it really nails this down to nowhere. But you stop the drug, and there's a sort of rebound, which we've come to call the rebound effect of denosumab discontinuation. Same thing is shown with P1NP. So we knew from the very beginning that this was something that could be a problem. This was a study by my colleague here at the NIH, Allison Boyce, from 2012, when we treated a boy with really dramatic fibrous dysplasia. So denosumab in high turnover rare diseases, there's dangerous initiation hypocalcemia and discontinuation hypercalcemia. So this boy, again, you can see here was his baseline, very high CTX. He started on the drug, it really went down. This boy, unfortunately, was sort of lost to follow-up and went back to Michigan, and we lost touch with him. He showed up in a little local hospital with severe hypercalcemia after self-discontinuing denosumab. And this gave us, anyway, the first hint at really how terrible this discontinuation hypercalcemia rebound can be in patients with high turnover diseases, which is what we see in some of the rare diseases. It's not confined to just fibrous dysplasia. This was another paper from a girl with juvenile Paget's disease who had severe hypocalcemia with initiation, 13 days in the ICU. So denosumab can be useful for these disorders, and I'll talk more about that in a little bit, but we've got to be aware of the side effects. Staying with OI, anti-sclerostin in osteogenesis imperfecta. So sclerostin is made by osteocytes. It inhibits bone formation by blocking Wnt signaling in osteoblasts. So therefore, it's an inhibitor of an inhibitor. It stimulates bone resorption by increasing rank ligand, and autosomal recessive sclerostin deficiency causes high bone mass disorders, sclerostosis, and von Buchan's disease. So romosozumab, anti-sclerostin monoclonal antibody approved for postmenopausal osteoporosis. There was a phase 1 trial, I say just opened, that's a little bit dated. I'm not sure exactly where this trial is right now. But I haven't heard much about it. It was to evaluate romosozumab in children and adolescents with osteogenesis imperfecta. Ultragenyx has licensed setrusumab. Phase 2 trial completed in adults with OI. Phase 3 is recruiting. September 2020 received FDA rare pediatric disease designation. This was some of the top line results from that study, 112 adults, randomized, double-blind, dose-finding study, no placebo, 3 doses. Unfortunately, the primary endpoint of this study, which is change in trabecular volumetric bone mineral density of the wrist by HRP-QCT. Some could argue this was perhaps not the right endpoint. It wasn't met largely because of subject heterogeneity. Secondary endpoints were all met. So in September 2020, they got the rare designation. Phase 3 trials in the works. I think we're going to hear some results about this study at the ASBMR meeting in Vancouver next week. So that will be good. Another potential or emerging therapy for osteogenesis imperfecta is anti-TGF-1 beta. So transforming growth factor beta, important regulator of bone remodeling, increased TGF-1. TGF beta is associated with decreased bone mass. These were preclinical studies published in 2014 using anti-TGF beta in various types of OI, which showed that this mouse model, these are mouse vertebrae, it tremendously increased bone mass. Fresolimumab was an investigator anti-TGF-1 beta monoclonal antibody. Brendan Lee and a multi-center group did a phase 1 trial in adults. They showed safety of fresolimumab in the treatment of OI. And this is now under development by Sanofi, and I'm not sure where that stands as of now. So, osteogenesis imperfecta in adults. Clinical trial, this was just published, very nice review of this in June of 2023. Clinical trial data are limited, were the conclusions. Bisphosphonates and teriparatide may improve bone mineral density. Research is needed to identify medications that will decrease fractures. Okay, turning now to one of my favorite diseases, fibrous dysplasia. So denosumab and fibrous dysplasia. So rank ligand is highly expressed in fibrous dysplasia. Case reports and retrospective analyses suggested denosumab may reduce the activity and progression of FD lesions. However, as they reported, there are severe derangements in calcium homeostasis can occur with initiation and discontinuation, requiring very close monitoring by someone experienced in these conditions. My colleague Allison Boyce here recently completed a phase 2 trial in adults with fibrous dysplasia. I'll show you the results in just a second. A pediatric trial is underway. This is the results of the adult trial, recently published in the New England Journal. You can see the effect on bone turnover markers was profound. These are sodium fluoride bone scans, which show active areas of fibrous dysplasia. Very profound results. The patients felt better. They did great. There were a number of very interesting findings that were identified on bone biopsies of these patients that I won't go into, that suggest that it really targets fibrous dysplasia at its pathogenic core, something that's being studied in this pediatric trial that Dr. Boyce is doing. But again, these patients, even when they were being watched like a hawk, between doses, in this one patient, she got away out of the corral and her calcium got up to 24 milligrams per deciliter. I'd never seen a calcium that high. She was treated inpatient. She recovered. She did well. Nonetheless, if you're going to use this drug, you have to know what you're doing and have to be careful with it. Okay, going to turn now to achondrodysplasia, achondroplasia. Shown here, a cartoon, what is involved in the pathogenesis of achondroplasia. It's the most common non-lethal skeletal dysplasia, 1 in 25,000 live births. It creates a rhizomelic shortening, metaphyseal flaring, enlarged cranium, and narrowed foramen magnum. The most common, this is due to heterozygous activating variants in the gene encoding fibroblast growth factor receptor 3. It's a tyrosine kinase receptor. FGF23 activation negatively regulates both chondrocytes, differentiation, and proliferation. Now, there are a number of drugs that are in trials and one approved for this. They are shown here in green. So there's the soluble FGFR receptor, Recifercept, that's in trials. Let's see, Vorositide is approved as one, I think is in TransCon CNP, is also in trials as well. The tyrosine kinase inhibitor infigratinib, which is a pan-FGF receptor inhibitor, is also in trials. So phase 2 trial of infigratinib, phase 2 trial of Recifercept, and there are 2 CNP inhibitor drugs. One acts at NPRB to stimulate growth plate. This is TransCon CNP. It's in phase 2 trial. And vosoritide was approved in 2021 for the treatment of achondroplasia. And the results of that trial, which are shown here. And as you can see, this is effects on annualized growth velocity. It has clear effects, statistically significant effects, but in fact, they aren't dramatic effects, and I'll leave it at that. Okay, moving on to FOP, fibrous dysplasia ossificans progressiva. So it's ultra rare, about 900 cases, dysregulated chondrogenesis, heterotopic bone formation that's driven by inflammation, severe disability and early mortality, as you can see in this skeleton of a patient from the Netter Museum in Philadelphia. It's autosomal dominant. It's due to activating variants in activin receptor A type 1. ACVR encodes a type 1 BMP receptor, and it's hyperresponsive to BMP, and non-canonical ligand activin A converts this BMP receptor to an activin A receptor. This too, for a rare disease, has a lot of drugs that are in the pipeline and one that's approved. So Investigational drugs, rapamycin, a trial, phase 2 trial in Japan, garetosmab, phase 2 trial. This was a phase 2 trial that was recently completed. The results are very promising. Phase 3 trial is underway. ALK2 kinase inhibitor phase 2 trial underway. Palovarotene was actually approved. That phase 3 trial was completed. And this was a complicated trial. The drug actually didn't meet the primary endpoint initially, but there was a reanalysis of the data, and it was looked at again, and the FDA advisory committee voted 10-4 to approve, and it was approved just in August 2023. Garetosmab, in my opinion, the drugs, the effect looks to be much more profound. Phase 2 trial is very promising. Completely stopped new lesion formation. The phase 3 trial is underway. This was published in Medical Archives in 2023. Okay, so that was a lot in 1 hour. So the last really 10 years, I'd say, there's been an explosion in drug development in rare bone diseases. It's really hard to keep up with. What we really need for these trials is more natural history physiology studies. These natural history physiology studies are really what we compare our new therapies against, because appropriately controlled, randomized, placebo-controlled trials most of the time aren't possible. Very important to have patient buy-in, patient involvement. The patient support groups from the RBDA have really been critical players in all of this. So our increased understanding of genetics and physiology underlying these diseases is lighting a path to the world of personalized and precision medicine, which is really making a huge difference for our patients. And with that, I will stop.